Hello and welcome to this lesson, ductal carcinoma in situ. So first, let's understand what is ductal carcinoma in situ. This is one of the non-invasive cancers of the breast, and it is cancers of epithelial cells that are lining the ducts of the milk. So in the breast, we have three main structures in the breast. We have lobules that are responsible for production of the milk. We have ducts that are responsible for transferring the milk from lobules to the nipple, and also we have fatty tissues surrounding the breast structure. So in the case of ductal carcinoma in situ, we are going to have cancers of epithelial cells that are lining the ducts in the breast. So this is a cancer that has not spread into the stromal tissue. It has not spread outside of the ducts of the breast, and that's why we call it in situ. Another point is that this cancer usually does not form a palpable lump. The cancer cells are actually very small and within the ducts of the breast, and that's why we call it a zero-stage breast cancer. But note that in case of ductal carcinoma in situ, unlike invasive ductal carcinoma, the cancer cells have not breached the basement membrane and myoepithelium of the breast and also stromal tissue of the breast. But if ductal carcinoma in situ is left untreated, we have potential to progress to invasive ductal carcinoma of the breast. And also estrogen plays an important role in case of ductal carcinoma in situ because it stimulates proliferation of the cancer cells and also promote the growth of cancer cells. Another point about ductal carcinoma in situ is that this is a cancer that is happening usually in the women who are older than 40 years of age, and peak incidence of this cancer is 50 years of age. So here in this picture, you can see the difference between a normal breast tissue, a normal breast duct, ductal carcinoma in situ, and also invasive ductal carcinoma. So here in the left side, we have basement membrane, we have myoepithelial tissue, we have myoepithelium, and we also have epithelial tissue lining the duct of the breast. In case of ductal carcinoma in situ, as you can see, the basement membrane and myoepithelial cells are not touched, and the cancer cells are within the ducts of the breast. But in case of invasive ductal carcinoma, as you can see, the basement membrane and myoepithelial cells are breached and they are outside of the duct of the breast, and they are in the stroma of the breast. Now let's talk about histology and grading of ductal carcinoma in situ. First of all, note that the grading is based on abnormality of the cells, because different grades of ductal carcinoma in situ can give you different shapes of cancer cells. In case of low-grade ductal carcinoma in situ, we have epithelial cells, we have cancer cells that are looking absolutely normal, almost absolutely normal. They grow very slowly and they are very similar to epithelial cells of the duct. And in case of low-grade ductal carcinoma in situ, we have very low risk for malignant progression and progression of the disease to the invasive ductal carcinoma. We have intermediate grade. In this case, we have cancer cells that are looking a little bit less normal. They are growing a little bit more rapidly, and we have a slightly higher risk for malignant conversion to the invasive ductal carcinoma. In case of high-grade ductal carcinoma in situ, which we also call comedoductal carcinoma in situ, we have cancer cells that look abnormal. They do not look like epithelial cells of the duct, and also you are going to find central necrosis in the ducts of the breast. And also because of the fact that we have many cells inside the ducts of the breast, you are going to have comedo, which is the plug duct, meaning that the duct is obstructed by the cancer cells. And also note that the grading is going to affect the treatment plan for this disease, and also it is affecting the prognosis of the disease. So the higher the cancer grade is, that we have less favorable prognosis for ductal carcinoma in situ. So what are the diagnostic tools that we can use in case of ductal carcinoma in situ? Mammography is one of the most important tools that we are using in case of ductal carcinoma in situ. Note that most of the women who are suffering from ductal carcinoma in situ are older than 30 years of age. That's why mammography is better than ultrasound in case of ductal carcinoma in situ. And on the mammography, you are going to see a very small tumor which is microcalcified. We need core needle biopsy in order to confirm the diagnosis, and also core needle biopsy gives you enough of the tumor in order to grade the tumor and also helps the staging of the tumor. Another tool that we can use in case of ductal carcinoma in situ is MRI or ultrasound, and ultrasound actually gives few information. It gives information about the size of the tumor and also gives information about possible extension of the tumor cells to the ductal system. On the ultrasound, you see something like this here. You see a hypoechogenic dark area within the breast tissue. So now let's talk about clinical symptoms and risk factors for ductal carcinoma in situ. Family history is very important, and also presence of genetic mutation, BRCA1 and BRCA2 mutations. These are two mutations that puts the patient in increased risk for ductal carcinoma in situ and also invasive ductal carcinoma. And also note that because of the fact that estrogen is affecting cancer cells and promote the growth of cancer cells, the high level of estrogen and the more exposure to the estrogen is going to increase the risk of ductal carcinoma in situ. So the late menopause, early menarche, null parity, and hormone replacement therapy, all of these conditions puts the patient on the increased period of estrogen exposure and also increases the risk of ductal carcinoma in situ. Usually the patients who are suffering from DCIS are asymptomatic because the tumor is actually very small and is not palpable in the breast, and the tumor is usually found during the routine mammography in this group of patients. The patient may have a nipple discharge, and if the patient has a palpable mass, it means that the ductal carcinoma in situ is actually extended to the stroma of the breast. Now let's talk about treatment options and prognosis of ductal carcinoma in situ. So note that the main goal of the treatment is to prevent the progression of the ductal carcinoma in situ to invasive ductal carcinoma. So we have few surgical options available. We have a lumpectomy, which is a breast conserving surgery, and it is usually reserved for a smaller ductal carcinoma in situ. But in case we have extensive ductal carcinoma which presents with a lump, or multifocal ductal carcinoma in situ in different areas of the breast, we can use mastectomy. But in case of both mastectomy and lumpectomy, we can have an adjunctive radiotherapy in order to prevent further development of next ductal carcinoma in situ. We have hormonal therapy. Remember that estrogen is one of the stimulators of the growth of the ductal carcinoma in situ. So if the histology says that we have a receptor positive ductal carcinoma in situ, we can use tamoxifen or aromatase inhibitor for a specific therapy, a specific hormone therapy. And another point about DCIS is that this disease has an excellent prognosis and very high survival rate, especially if the tumor is a low-grade tumor, and recurrence is possible, but and that's why we monitor patients with mammography in different intervals. And bigger tumors, extended DCIS, and necrosis are bad prognostic features that you have to know for your board examination. Thank you for watching.